Okay, so today we're going to start out talking about public health programs and their evaluation and their review. So if you're using epidemiology to measure program effectiveness, if you want to measure the program effectiveness of any program, yes?
So a lot of us in the class, we use Adobe Reader to take notes and add notes onto your PowerPoints, but this one's secure. Do you have the password to unsecure it so we can add onto it?
I don't think so. Why can't you? You always can add onto it. And
Secure. We need a password to unlock it.
no, you do. You can do commenting on it, can't you? Oh. I don't honestly know the password. My secretary does it for me, so I can't tell you. Any other questions? Okay. Okay, so you might want to use epidemiology to measure effectiveness of any program that you might have in public health. It's important, and this is the way that most of the programs are going. They will not give you public health dollars if you do not show that you're doing something good. And it always has to be a measurable outcome. So you need to choose a variable that can actually be quantified. Yes? Okay. I think he got that. That you can duplicate the PDF and then it's not secure.
Don't worry about me.
Okay. She's worried about you. Okay. And the measurement needs to be easy to do because a lot of times programs are really short funded. I run a program for the entire state of New York for osteoporosis education. We get $100,000 a year and that's it. So when you have that short of resources and you're supposed to provide the education as well as evaluate outcomes, it's really hard to do all that in short money. The measurement should lend itself to standardization. So if you have different centers, that they can all look at the assessment in the same way. And the population served for your program should be the population at risk for whatever condition the intervention is being evaluated. So you don't want to test your program if you were doing a teenage exercise intervention. You don't want to test it in a group of old people and say it works, we're going to do it in teens. You want to test it in the population for which you will actually use it. So if you are using, I'm sorry, did I skip this slide? So if you're using epidemiology to evaluate various health services, there's various steps that you need to follow. You need to collect the baseline data, you need to implement the program, and then evaluate the program, perhaps by collecting the same data or information as you did at baseline. So a lot of times, because we're an education program, we deal a lot with pre-test, post-tests. So we'll go into a school district and we'll give all the students before they get their bone health education a pre-test, and then at the end of the program we'll give them a post-test and look at the change in knowledge. You also want to try, and on the basis of whatever evaluation you did, try and determine what other program activities could take place in the future and kind of build on whatever you have already started with. So if we want to think about, a simple example, something like endpoints for a vaccine program effectiveness. So this is something that's in the news now because at Princeton University, they're worried about this meningitis swarm that they have there, and they brought in a vaccine that's not approved yet in the United States, and they maybe are going to administer it to their students because I think it was approved in France or something, but they're worried about this particular strain of meningitis that they don't have a vaccine that's protective against it. So if you were trying to look at the success of that program, you might want to look at the number or the proportion of people that were immunized. If you offer it to the whole student body at Princeton, what % actually end up taking it? Or the number or proportion of people at high risk who are immunized. So maybe the cases, I don't know if it's 6 or 8 cases that they've had so far lived in certain dorms. You might consider them to be higher risk, the people that live in the same dorms. So maybe you do it like that and say what % of the people at higher risk actually took it. Or they're talking about maybe only saving it for people that are somehow immunocompromised. So you could call that your high risk group and see how many of those got the vaccine. Then you can actually look for a serologic response in the people that you give the vaccination to. Do you actually see a change that suggests that they now are immunized against this strain of meningitis? And then you could just say, well, how many people out of the people we immunized, how many of them actually did go on to get sick versus the people we didn't immunize? Is there a difference? Did we really protect these people against getting disease? So those are the different kinds of endpoints that you might want if you were dealing with something like a vaccine endpoint. So in most of our studies, we've been kind of looking at etiology. We've been looking at various environmental factors that maybe lead to a health outcome. Because you're all in a nutrition program, we tried to focus on various nutritional risk factors that maybe lead to various diseases. Now, one of the confounders, or something we might want to control for or think about controlling for, might be, say, healthcare. Is the person that we're looking at this relationship insured or not? But when we are looking at health service evaluation, we kind of turn it on its side, and now all of a sudden our interest is whatever we're doing in terms of healthcare, and we're looking at health outcomes, but we might need to actually control for nutrition or physical activity or some of the environmental factors that we have looked at here. So this would be like the independent variable, this is the dependent variable, and then potential confounder, and we're kind of changing their places here and saying, you know, now instead we want to evaluate healthcare, not just control for it in this relationship, but evaluate it on its own. So there are various programs that can be evaluated using group data. Sometimes we have to use data like mortality data, hospital discharge data. These are often used because they're available. You can get them from online programs, and you can apply for them to do studies that you want to do. So research studies that compare the effects of 2 or more healthcare interventions or treatments or insurance on health outcomes or economic outcomes, they usually use very large databases and data sets. Some of the more common ones are the National Hospital Discharge Survey or the National Health Interview Survey. These are 2 of the largest ones, but you have to understand that even though they're large data sets, there are differences in them. So that if we actually look here, this is the National Hospital Discharge Survey data, and this is the National Health Interview Survey data, looking at short-stay hospital discharge rates. So both of these are supposedly looking at the same thing. They're 2 different sources of discharge rates for short-term hospital stays. So they are showing, in terms of absolute rate, 2 totally different things. But what they are both showing is the trend, where it was kind of everything was leveled off, and then around 83, it started dropping down in terms of the rate of hospitalization. So there could be different absolute differences, but hopefully they will show the same kind of trends. So if you actually had an intervention that you started here, you could actually see whether or not you had any impact in either of these databases, because in both of them you show a decline. It's just the absolute number is a little bit different. So the gold standard for program evaluation or for individual level data is the randomized controlled design, where you can really compare care. So you would talk about the eligible population, you would randomize them to the assignment of care A or care B. So maybe this is a surgical intervention for cardiac disease, and this is a medical intervention. You know, it can be mammography and usual care. It can be a lot of different things that you're looking at where you're trying to see what is the best care for my patients in order to make sure that a greater proportion improve as compared to not improve. So just like we've done this for a regular evaluation of any risk factor, it's the same thing. It's just that now we're looking at, instead of, say, vitamin A and placebo, we're looking at various types of care compared to other types of care. And maybe it's a new system of care or evaluation a new service, like a lot of times they come out with certain measures that you have to try and meet, like performance evaluation measures within a hospital. So sometimes they'll look at this at a point in time, you know, where some hospitals are randomized to start these performance measures and others are not, and see whether or not the care or the life of the people improved on the basis of the new care. And just like in evaluation of risk factors, you can also use a cohort study. You can also use a cohort study to evaluate health services or health programs. So you have your eligible population, but here they're self-selecting to utilize the program or to not utilize the program. And then you're again looking at whether or not the disease improves in those that utilize the program as compared to those that do not utilize the program. So what is one of the downsides of using this cohort study? Yes?
Well, I think especially in this case, because it has to do with like selecting healthcare versus not selecting current healthcare and treatment, there's like a huge selection bias because if they are utilizing the program, they might be healthier or have different habits than those who don't utilize the program.
Right, so just like any other cohort study, we're worried when people self-select a healthier thing, whether it's a better diet or exercise, or in this case, improved medical care options, that they might have a whole lot of other differences. And that's the problem with the cohort study, is that we're always worried about these people being a little bit healthier than the rest. So here is an evaluation where there was people that were either before they received this special care called T or after the special care. So in the red line, they received the care, and in the black line, they did not. So this is actually looking at the morbidity level, how many people actually got sick between those that used the health service, so that's getting the care, versus those that did not. So if you do not have this first measure, so here if you have this first measure, does it look like there's a difference between them? Like, which seems to be a better thing, receiving the care or not? Right, so if you receive the care, you're doing a little better. Here, but look at here, if you didn't have this baseline and you just looked at the differences here, you have the same differences here, but look at, they both started at 2 different time points. And that's why it's a big problem if you just evaluate things after the program started and get no baseline data. Because without that baseline data, you don't know, does this reflect the original differences before getting care? You don't know if you don't have that baseline data. Yes?
Wait, is this a time measure or is it just morbidity level? Is the second graph?
They're both morbidity level. So this is just before getting the care, and you actually assessed it, and here it was different. Or you make an assumption that it was the same, and then look at where it is now. And that's what I'm talking about, that you have to kind of always, it's not great to have a program evaluation just at the end of the program, because you don't really know where the population started, and they could be different. Yes?
For the first picture, though, I guess I read that as if you did not receive care, your morbidity level actually went down further than if you did receive care.
Yeah, it actually, you're right. But the graph must be reversed, because to receive care and have it be worse, I'm thinking that this has to be like the percent free of disease, like we're used to looking at, is the only way it makes sense. You know, so I took this graphic, but as I was saying it, I'm like, well, this doesn't make any sense, but I didn't want to confuse anyone. So just assume this is like the percent of people that, you know, don't have disease or whatever, and you maintain that. But see, then you're not showing an improvement after care, so I can't figure out how to make sense of this. So let's not call this morbidity level. Let's just call it how you doing. And if you're doing well, you're down here, and if you're not doing well, you're up here. So you're, you know, how you doing is not great here, but as you get the care, it goes down. But see, then how you doing here should be better. So, like, I guess the point I want to make here is that, you know, we do care about how you're doing here, but it makes sense to know how you're doing at the baseline, or else you can't really follow up and see what's changed.
I mean, this one is basically saying that for the first picture, that by whatever this care was, it actually hurt the individual so that this treatment is ineffective, whereas in the other one, it's showing Well,
there was no
were
change.
two different, and there was no change.
But
so
see,
it would actually be better to have the second one.
well, it would be better, but neither one is really what you want with a program evaluation. If you're doing a program evaluation, you want it to be better, not the same, which this shows, and not worse, which this shows. So I'm going to scratch this graphic for next year. Okay. So because of possible selection bias when people self-select, it's a problem. And it's the same thing when you do a cohort study and they're selected by eligibility. What makes someone, say, eligible for a certain insurance program versus not eligible? It could be a big difference of, also, are these people at a higher socioeconomic status, and that's why they're eligible? And so you get the same kind of problems whenever you have people selecting themselves or when they get put into a different program based on their eligibility. There can be some defining characteristics here that makes it likely that it might impact the prognosis. So this is always a concern, that what are the criteria to be eligible, say, for a certain health insurance plan? And is it possible that that actually is impacting whether or not someone improves in terms of their care? And if it is, then you have an issue, because then you have the bias, just like the cohort study that we talked about before. So when do we use some of these data? One of the things that happens is you might look at adjusted operative mortality. This is looking at all Medicare patients according to surgeon volume, for 4 different cardiovascular procedures on the top and for 4 different cancer resection procedures on the bottom. So what they're defining here is operative mortality is the rate of death before hospital discharge or within 30 days after the procedure. And then the surgeon volume is total number of procedures performed per year. So if you look at this, this is the annual surgical volume, and this is how many people actually die. So let's look at this. This is aortic valve replacement. So if you look and the person does less than 22 per year, the mortality rate, or the adjusted operative mortality rate, that short term right after surgery, is up at around 9.1. Whereas if they do more than 42, it drops down to 6.5. And that's a big difference. And that is why you have people, like I brought my mom here, and Dr. Ozit did it, and he was at the time a real surgeon, not a TV star. And he actually, was doing a ton of these. He would do several a week. So he was way above 42 per year. And you choose a, good center because you know that if they're doing it more often, chances are that you get a better outcome. And it's the same thing was true for some of these oncology procedures, although not as clear. So here's pancreatic resection. So less than 2 and then more than 4. And you can see that the rates go down from 14.7 to 4.6. So data like this that was published and has come out is partly why people go to referring centers when they have a major procedure to be done. Because where not only the surgeon and how often he does it, but there's a doctor here, I think he's a OBGYN for cancer, and he did a paper with Al Nugget, who I used to work for, who's also a cancer oncologist, and they did a paper that was looking at how large the medical center was versus what is the mortality after various procedures for cancer. And there they also found that your mortality is much higher at the smaller community hospitals as compared to the major medical centers. So part of it is this, because you're going to have higher volume at the higher ones. But even if they controlled for that, it still seemed better. And the concept is that if you're here, say for aortic valve replacement, but all of a sudden you throw a clot, there's going to be a specialist walking down the hall that you can quickly grab in. And so all of this data comes from using large data sets that are available out there and can be used to answer questions like this. So this is looking at prenatal care on neonatal mortality. So these people received prenatal care, and these people did not receive prenatal care. So this is the number of births, and this is the number of neonatal deaths, but you can't just look at the number of deaths because there was a hugely different number of births. So if you look at the neonatal deaths per 1,000 live births, you can see that in those that received prenatal care, it was down to 30.1, whereas those that did not receive prenatal care, it was 88.9. So the question is this a bias? Are those who come for prenatal care just healthier? Like, how real is this data? Is it really the act of the prenatal care, or is it also that they take better care of themselves, and so not only do they go to prenatal care, but they might do other healthy things for themselves? They're probably less likely to smoke and things like that. And that is why whenever you see data like that, you would hope to see that somewhere down here they say this is even after accounting for smoking status or, you know, economic status, something like that, to try and, you know, normalize some of the other factors and see if it strictly is related to the prenatal care. So here's the service, and what I talked about before is the different confounders you want to control for, and now the things we're used to actually studying. And that's what you want to control for when you're evaluating the service. So one of the questions was, if sore throats are treated, can rheumatic fever be actually prevented? So this is looking at rheumatic fever incidence in people aged 5 to 14, so in children per 100,000. And this is comprehensive care, and this care was based on the census tract where people lived in Baltimore. So here they got comprehensive care. These were the tracts where they didn't get comprehensive care, so they were the census tracts without it, and then together they make up all of Baltimore. So it appears here that if you have comprehensive care, the rates of rheumatic fever in children tend to be somewhat lower. So was it the care that was actually being given? So one of the things was it really just like a change over time or something like that occurring? So what they did is they said, okay, let's go back before we started this comprehensive care. And in the period 1960 to 64, where all of these are kind of even, what was the rates like? And in fact, where they instituted the comprehensive care was even higher than the rates where they didn't institute comprehensive care. And so when you look at the before versus after, you can see this huge drop in terms of, it was a 60.4% drop in rheumatic fever incidence because of starting this care for sore throats. Here, the rate was normally lower in the past, and it stayed there because you hadn't done anything. And then again, this is all of Baltimore, so it's combining these two. So the question is, well, was it really related to the first infection? And so what they did here is they looked at, well, how many of these incidents of rheumatic fever actually came from someone that had a prior clinical infection? If our program is trying to treat someone with a sore throat to make sure they don't go on to rheumatic fever, then we would want to see what they actually saw here. So if there was no prior clinical infection, of course there wasn't any sore throat or anything to take care of, and there was no change in the rates. But in those people that actually had a prior clinical infection, they had a huge drop in the rates. So all of the decline in this rheumatic fever incidence was limited to those with a prior clinical infection, making it seem that the program did work. Yes?
Going back to the previous slide, how can you show rates of comprehensive care if there was no comprehensive care?
Well, it's not the rates of comprehensive care.
Rates of treatment.
Well, it's the rates of rheumatic disease in the comprehensive care district. So in other words, they're saying, you know, this is the comprehensive care census tract. So this was a group of census tracts, this was another group. And they were looking at before and after the change in those population areas. Okay. So sometimes we want to apply epidemiology to evaluation and to policy. And so it starts us asking certain questions, like how much epidemiology data do we need to justify a prevention effort? And then for primary prevention, remember that's preventing disease in well people. It might depend on the severity of the condition that you're trying to prevent, the costs of doing the primary prevention, whether there's any evidence that primary prevention actually would help, and whether you have the ability to eliminate exposure. Secondary prevention is really trying to identify the disease at an earlier stage. That would again depend on the severity of the disease. Can we detect the disease earlier? How expensive is the detection? And does earlier diagnosis benefit the patient? Some of the same questions that we brought up last week, because a lot of secondary prevention is the institution of screening programs. Yes?
So just to clarify, primary prevention is in healthy patients, and secondary prevention is in unhealthy patients, but just at an earlier stage of the...
Yeah, so they're the ones that are really that have the disease and or are close to getting the disease, like maybe have risk factors. So primary prevention is kind of, you have a normal, healthy population, and you're going to teach them not to smoke, you're going to teach them to exercise and eat right. Then secondary prevention might be someone like in the field, I know osteoporosis, they have low bone density. So they're at greater risk for going on to get osteoporosis. So in those people, you might want to consider, you know, fall intervention and maybe considering a treatment or maybe, you know, giving them some physical therapy or something. So you put in a little more effort because they're at a greater risk for the disease. Tertiary prevention usually is those that already have the disease, and what are we doing to take care of them? So this is really what we spent most of the semester on. We had risk factors, and we wanted to know whether they related to disease. Yes?
Tertiary prevention, if they already have it, wouldn't that just be controlling or treating versus preventing?
No, so if you have tertiary prevention, a lot of times it's, say, giving them assistive devices for walking after they've had a stroke, or, you know, something that you do to try and improve their care. They already have the illness, and now what can you do to improve, say, their quality of life or make them live longer? So it's not like, you know, a strict criteria. And for some diseases, it's not as clear because you don't have a true risk factor, like, say, with the osteoporosis, where a low bone mass we know can go on to osteoporosis bone mass. For other things, it's not as clear cut, but you might have just a collection of risk factors. And that's where you would aim your secondary prevention. And then the tertiary prevention would be, okay, you already had a heart attack. What can we do to prevent another one? Or you already have cancer. What can we do to make you live longer? Okay, so this is really what we spent most of the semester on. We talked about the different diseases that we can try and think about nutritional risk factors for. We talked about the different study designs we can use to try and look at this whole association. But what I want you to do is just kind of expand what we talked about before and think about what are the factors that determine exposure to the risk factors. You know, so say if the risk factor was lead and leading to lower IQ, so what are some of the factors that maybe would expose someone to lead? Yeah.
Like living in a New York City building that has lead paint.
Right, so an older building that might have lead paint. Where they work? Yeah. In the water. So it's looking, or maybe a poorer neighborhood. Like, so you try and figure out what are the things here, because some of the risk factors, you know, we want to go back a step and we want to think about, well, is there something we could have done sooner to try and take care of this? And this is something that was done where they realized that a lot of it was coming from lead paint, and they did a while ago these lead abatement programs where they tried to go into households and get rid of most of the lead-based paint. And the other thing is that I want you to think about, we can also study what is the impact of the disease. Like what kind of an impact does it have on social, psychological, family, economic, community effects? You know, caring for a person with Alzheimer's disease, what is the impact on the family? What is the care that you need to give? And so I want you to just think before the disease of other factors and after the disease of other factors as well. And then the other layer that comes into play is that sometimes you're exposed to risk factors, but you don't always get the disease. And there's various reasons. So Monique gave a lecture talking about genetic factors that might influence susceptibility or vulnerability. So we did talk about this a little bit. There's also environmental and social factors that maybe will impact whether you go from a risk factor to a disease. You know, if you put on weight but you belong to a community that's got a great gym and it's got a great program for you to go to, maybe that will help you lose weight so it doesn't go on to whatever disease. And also a lot of these social factors can influence these environmental and social factors as well. So again, just bringing out the model from the simple one that we've looked at and thinking of it in a little more detail is important, because really epidemiology can encompass any of these different things on the graphic. There's a lot of people that do outcomes research, and that's strictly looking at the disease and how they progress and whether or not with certain drug treatments they do better or not. So outcomes research is a huge thing, and that's beyond the disease. It's what is the outcome or the effects of the disease on other factors. So some of the other questions is whether prevention efforts should actually target high-risk people or the general population. The risk of death from coronary heart disease steadily increases with increases in diastolic and systolic blood pressure. We've known that for a long time. So if we look at this figure, it's basically showing 300,000 females screened, men screened for Mr. Fit, and it's looking at the percent distribution of baseline systolic blood pressure is panel A here. So these had less than 110 for their systolic blood pressure, and up here 140 to 149, and all above here. So the blood pressure that was high or something greater than 140 in systolic blood pressure was about 25% of the population if you take this part here. So about 25% of this whole population ended up having blood pressure that would be considered to be hypertension. Then you look at the relative risk of coronary heart disease death, and you can see that as the blood pressure goes up and up here, you get a higher and higher risk of death. So if you look at where 140 is here, almost all of this really high elevation in coronary heart disease death is related to those with the blood pressure over 140. Then if you look here, it's the percent of excess coronary heart disease deaths. So again, if we use that 140 cut point, which up here was about 25% of the population, if we look here, it's all of these bars here are included. So about 2/3 of the excess coronary heart disease death are related to those with higher blood pressure, which was only about 1/4 of the population. Yes?
What do you mean when you say excess coronary heart disease? How is it that excess?
So it's in excess of what you would expect for someone at that age. And so it's just the blood pressure is going up and you're getting a greater and greater risk. And that's what's being shown here. So your relative risk keeps on going up, and that's compared to someone, say, your age that's a normal blood pressure. But the big thing here is that you only have 1/4 of the population that has the hypertension, but they're leading to 2/3 of the disease that you have to treat later. So the concept is, what should you be doing? Where should your interventions be targeted? That's the point that I kind of wanted to bring up here. If you have, this percent that's leading to all of this excess coronary heart disease mortality, do you want to target programs to everybody, or do you want to select certain blood pressures to start targeting programs? What would you think? So if you wanted to do a public health program and you wanted to try and prevent excess coronary heart disease deaths, would you target everybody, or would you target higher risk, or what would you do? It might be that by targeting the higher risk, you get more bang for your buck. So if you make sure that anyone that comes into a doctor's office with hypertension is, say, given a brochure and treatment ideas and talk about what kind of lifestyle changes you can make to prevent heart disease, that might be a more targeted intervention. So your only resources are only impacting about 25% of the population, but you are going to get rid of about 2/3 of the disease that occurs later. And it's not that that's the right answer, it just is one way that maybe you want to go if you have limited resources. And if you were doing primary prevention, you really wouldn't care what their blood pressure was. You would try and get all of these people that were free of heart disease and try and prevent them from getting a coronary heart disease. Yeah?
Could you say, based on this, that to get the most bang for your buck, that you kind of should be shooting for people with the 130 up to about just under 170, so the 169, because that's really your big portion, and then technically those people that are above,
Right, you could do that too, because even here, like this is 25%, so here you're getting up to about 40% or so. So you could still impact, like only talk to 40% of the population, and here you'd be getting rid of almost all the disease. And in fact, that is how people look at this. So whereas 140 might have been the target blood pressure now, 130 might be the targeted blood pressure now. You know what I mean? So over time, as they see data like this, they drop the blood pressure level where you want to think and pay attention a little bit lower, precisely because of the question you asked. Okay, and so what our goal is, like if you have a population strategy, you know, what you're trying to do is just shift this whole curve. So if this is the normal distribution of systolic blood pressures in the community, after your intervention, you're just hoping to shift this whole curve to the left. So what happens is that you have fewer people in the tails out here with high blood pressure. And that's what you can hope to do, is just kind of, you're not going to stop people from getting hypertension, but if you can at least bring all of their blood pressures down by an increment. And this was the purpose of programs like reducing salt consumption and things like that, you know, that are still controversial. But the concept there was if we can minimize the salt consumption of the United States, that maybe we could have this kind of effect, that the whole distribution shifts this way. So there was, I talked a little bit about hormone replacement therapy and how it was used. In the past, it used to be used a lot to kind of stop all kinds of disease. So it was thought that, you know, a woman goes through menopause, she stops producing her own estrogen. We're going to give her estrogen, and it's going to make her healthier overall. And what happened is there was a series of studies that started to show that that wasn't true. We had a lot of epidemiologic studies. This is a classic example where case control studies of cancer versus not, heart disease versus not, all showed that there was a higher use of hormone replacement therapy in the people that didn't get sick. Cohort studies went on, and the women on hormone replacement therapy overall were healthier than the other women. But they were all subject to the same bias that we've talked about all semester long. So then they finally did some randomized controlled trials. And the HERS study was one of the studies that was trying to show that if you give hormone therapy, you would lower the rates of coronary heart disease or all cardiovascular disease outcomes by giving the hormone therapy. And what they found is that after 6.8 years of therapy, there was absolutely no difference between the hormone group and the placebo group. So whereas our case control and cohort studies had all shown this was a benefit, this randomized trial showed that there was no benefit. And that kind of led on to people starting the Women's Health Initiative. And the Women's Health Initiative is probably one of the largest funded studies by the National Institutes of Health. And this, the WHI.org, you can go there and see all kinds of slides and all kinds of information about the study. But what it was looking at is for each of these different diseases that they did the study because they thought they were going to show benefits, what actually is the difference between those with estrogen and progestin versus those on placebo. There was no difference between the two groups for overall death or endometrial cancer. There seemed to be a benefit for both hip fractures and for colorectal cancer. Now, this was published in the original study, although this week a paper came out that said maybe neither of these benefits actually hold true. Then there was risks with blood clots, breast cancer, stroke, and heart attacks. And this study was actually stopped early because the perceived risk was worse than what they had anticipated. So there's always a data safety monitoring board that is in charge of reviewing data periodically, all of the adverse events, and seeing does there seem to be a lot more in one group versus the other. And I, serve and chair a lot of these DSMBs or whatever, and it's a very important job because you get the data from the study and you're supposed to look, and the safety of everyone in that study is on your shoulders really to evaluate the evidence. So in this particular case, they felt that overall the risk was exceeding the benefit and they stopped the trial early. And so if you were trying to think about your guidelines, say, for hormone therapy and coronary heart disease in women, what would you say about hormone therapy? not good, right? You probably would want people to avoid it. And even in something like where I come from, the hip fractures, showing that there was a reduced rate, even there we say this isn't your first line of defense because there are all these other risks associated with it, and there's other medicines that won't give the same risk, that is better not to use this. So in general, the guideline for hormone therapy on the basis of this study and others is that it should be used for the shortest amount of time possible, for a limited amount of time, and typically right after menopause. And so short amount of time, right after menopause, and that's about it. And the reason why it still is being used is because it does stop some of the symptoms of menopause. So if women are really suffering from lack of sleep, depression, hot flashes, all of those things, it may make them better. So I just want to talk about, like for a few slides, about the news that's been out there lately about the heart attack and stroke and the new guidelines. So they came up with a 10-year risk calculator for heart attack or stroke. I put the paper on Courseworks in case you wanted to look at this and just see where the evidence came from for what they're saying here. So what they did is they came up with a calculator that considered people's age, their gender, their race, their cholesterol levels, triglyceride levels, HDL levels, and whether they had diabetes, hypertension, and if they smoked. And the idea was to put all of this data into this heart risk calculator, and it would come out with what is your % risk of disease. Now, this was based on kind of pooling together a whole lot of different studies, cohort studies and things, and seeing how many people went on to get disease if they had diabetes, or how many people went on to get disease if they had elevated triglycerides. So on the basis of this, they came up with guidelines, and they basically said, put your patient's data in here. If you come up with a number that's greater than 7.5%, they're considered at elevated risk and therefore should be treated. Now what has come out is a group from Harvard has come out and said that, you know what, this risk calculator is all screwed up, and if we use it, we're going to really overestimate. Someone that really should have about a 4% risk is instead having a 7.5% risk. So there's a lot of outcry that this risk calculator that is the basis for their whole report may have some flaws in it. And I think we're going to have a lot of back and forth. And I'm hoping next year to just do a whole lecture on this, you know, because by then hopefully some of the dust would have settled. But this is in general, using that risk calculator, what they came down with. And they used all kinds of evidence. And just like when we talked about the trial evidence and causality, and we said these are the criteria for whether or not the evidence is good, you know, is it from a randomized controlled trial or is it from a cohort study? And they graded all the evidence and came up with these guidelines. And first it was, does the patient actually have atherosclerotic cardiovascular disease? And if they do, then you should go to the secondary prevention guidelines. If they don't, and they're between 20 and 79 years of age, you either see the pediatric guidelines or the adult primary prevention guidelines and discuss whether or not you need to control their blood cholesterol, lower any rates of obesity. If they're outside of that age range, then you're supposed to put this risk calculator using these pooled cohort equations. And these are the ones that are maybe flawed. So the whole thing is based on this. And if they have an elevation in their 10-year risk, or it's more than 7.5, then you should concentrate on trying to use a statin or something to change the blood cholesterol, as well as the prevention guidelines. The whole controversy has really been over the blood cholesterol levels and the use of statins and the risk calculator, and that's why I'm not spending a lot of time on the prevention guidelines. And if they have a low 10-year risk, then you just talk to them about the different lifestyle things that they can look at to try and be a little healthier. And this is the classification that they used for the level of evidence. So I don't expect you to really see this that clearly, but this is the size of the treatment effect. And was the benefit much, much, much greater than the risk, or was it a little greater than the risk? Is it, you know, maybe almost equal to the risk, or does it actually cause harm? So that's going across the top. So this would be like your relative risks, and how strong are they, or do they go in the opposite direction? And then this is the certainty that the treatment effect really exists. And that's based on how many different populations were evaluated, Did you have a lot of multiple randomized controlled trials or meta-analysis? Was it a single trial or non-randomized, like cohort studies? Or is this just kind of case studies and people's feelings? And so all of this comes into the chart, and they used all of this and clearly said, well, why are we saying use statins to this level, and why are we not? And so the intent was right, but the problem is that if you, if you put crap into an equation, you're going to get crap out. And the problem is, like, what is going on in that black box? Is it something that can be fixed? We have a similar thing that does this for 10-year risk of fracture probability. It's this FRAX thing, and you can go online and do it yourself. And it either can be done with or without bone density. And there's been a lot of controversy with that as well. But it was the same concept. Let's pool all of these cohort studies we have that show what are the risk factors for osteoporosis and see who ends up getting a fracture or not. So I'm not really going to tell you what the final answer is yet, because I think we still have to wait to see. But I want you to understand that the report that I left on CourseWorks, in case you want to read it, is based on this kind of an evidence grading. And it was a well-done report. It's just whether or not there were certain flaws in the studies that are an issue. And we face the same thing with a lot of the other things that I deal with, the whole use of calcium and vitamin D, and is it good or not good to use it? All of these are issues that have come up, and different trials are used that might meet all these criteria, but they have some other fatal flaw. And if people don't consider that, then they're using data that really is not getting at the point. So basically, statin benefit groups were identified for whom this risk reduction outweighs the risk of adverse events. So it was anyone with the disease, if they had primary elevations of LDL greater than 190, if they had diabetes age 40 to 75 years with LDL of 70 to 189, or without clinical disease or diabetes, but their LDL cholesterol was 70 to 189, and their risk was greater than 7.5%. And this is where a lot of the controversy is. And as I said, I think you're still going to keep on seeing it in the New York Times and other journals as doctors keep on evaluating it and coming up with what their feeling is in terms of how valid it is to use. So one of the things that comes into play with program evaluation and also the use of epidemiologic data is trying to think about risk assessment and risk management. So one thing is hazard identification. Is a chemical linked to a health condition? And this is where a lot of the work with lead and cognitive function all came into play. They studied lead and they looked at different levels of IQ based on blood lead levels, and they said, this is something we have to study. Dose response assessment, is it possible that the magnitude of exposure is related to the probability of a health condition? And this could be something like secondhand smoke, where it was decided that if people are working and living with people that are smokers, that their risk of lung disease actually is increased. And you can do an exposure assessment where you basically look at the extent of human exposure before or after regulation. So this could be done before and after the lead abatement programs. What was the blood lead levels in children before these apartments and buildings were fixed, and what was it afterwards? Or you could look at it secondhand, smoking regulations, like not smoking in public places. Did we see a drop in the lung cancer rates? And you can just describe risk, where you describe the nature and the magnitude of risk. And just like we had that big grid that came up with the for the meta-analysis of the cardiac guidelines, you also have to think about the different levels of risk in terms of risk assessment and risk management. So you can have research that's laboratory and field observations of adverse health effects. You can use different models for high to low dose and animal to human and trying to extrapolate. You could have field measurements where you estimate the actual exposure, characterize the population, and then you do a risk assessment and you kind of say, does the agent cause an adverse effect? Is there a dose response there? And what exposures are being experienced and where are they coming from? And then you try and characterize the risk and figure out, well, how can we manage it? Can we start with regulatory options where we say, no paint can be, have any levels of lead in it? Looking at different regulatory options and what would the impact be? because there's always economics, there's political consequences, things like the soda ban in New York City. There's always like another end to making a risk management decision. And that will impact how people act. So this could be lead paint in toys, it could be smoking in public places, it could be the size of your soda. All of this comes into play, and a decision is made as to whether or not they want to act on it. But we need to think about what is related to the disease, so we know where in the pathway we can try and stop the exposure. What really matters? Is it what gets to the target tissues? Then maybe we could act before the exposure. Is it the exposure that matters the most? Is there some way we can decrease the absorption into the body? All of these matter. So I want to just spend a couple of slides on meta-analysis because it's often used to answer public health questions. It was used throughout the whole cardiac guidelines. Many guidelines now do it based on meta-analyses. And they come into play, and a lot of people base their guidelines, their treatment care on these things. So, but it brings up certain questions. Can epidemiologic methods detect really small increases in risk? Maybe it can't with one study, but it can do much better with multiple studies where we pool all the data together. Sometimes we have inconsistencies between animal and human data. So how do we reconcile that? That was something that, the bladder cancer and the laboratory animals with different sweeteners, the saccharin, and then they said, study after study, they couldn't find the same thing in humans. So then they decided for some reason it was different in the animal. How can we use incomplete data? Like maybe now we know there's a new risk factor that we should have evaluated and it's not in those data sets. So how can we use them and still evaluate them? And when you have different studies that disagree, how do you kind of pool them together? And what does that mean? And how can you decide which are the better studies? And what is the way that you can actually kind of figure out which are maybe the better studies? What have we talked about? Yeah.
The size of the study and the design, the large randomized controlled trials like the best and small studies.
Right, so it's the larger study, the randomized clinical trial. You can use things like the causal criteria. How strong was the association found? Was it consistent across studies? So all of that comes into play in using the data. So this was the meta-analysis that was done in 9 different studies looking at exposure to environmental tobacco smoke and lung cancer. So if you look at all of these studies, there is not one single study that found a significant effect. This one was close, but remember, it can't cross this line to be significant. So all of these studies were basically negative, but they all hinted at a possible relationship. And so what was done was they did a pooled analysis and got a summary of the effect, which is shown down here. And so for all 9 of the studies, it appears that there's a very slight elevation in the risk that just nearly missed statistical significance. And that's why we do this, because no individual study is large enough really to show the small increase in risk that we expect. But if we do a meta-analysis, pool all of these different 9 studies together, we might get a better answer. The other thing is that epidemiology in courts has become really important. So there's been things about the safety of silicone breast implants, the effects of electromagnetic field radiation, drug effects like drug side effects. And, uncertainty is really part of our science. And the problem is that when it gets into the court, it's very hard because we can say it appears that something is causal, but it's very rare that we say this absolutely causes that. It's not very often that we can do that. And that's why a lot of times, in these kind of cases, it's your honor, we, the jury, find this one too close to call. And that's going to be a large part of epidemiologic science because we kind of pool everything together, get the best estimates, but it's not always a clear, resounding, this is a causal relationship or this is not. So this is looking at some of the decision-making process that we might have in terms of determining our policy and action. So we have scientific evidence. It might be limited. It might not agree with each other. So we become uncertain. So then we have to make a decision about whether or not we want to make a policy or take some kind of an action. And there's always going to be agreement or disagreement about the benefits and the risks. There's physician attitudes, there's patient attitudes, there's political, economic, and social values, public attitudes and perceptions. And you can just think about this, say, in the case of New York City trying to change the size of the sodas, and how much all of this came into play in the decision-making about the policy and the action, and how it could still end up in court. So I want to just spend a couple of minutes going through some of the papers that I gave you, and then we will take a break, and then we'll come back and have a review for the whole semester. So one of the papers that I gave you was alcohol-related mortality and morbidity among U.S. college students. And I just thought this was maybe a relevant paper for you at your age or whatever. So, yeah. How do you really, does anyone know how you define binge drinking?
5 or more drinks in one sitting.
For a male? And girls, what do we have to do? Yeah? 4 or more, right? So it's 5 or more in men and 4 or more in women. And that's what they consider to be binge drinking. Now, they went through and they asked and got various data on surveys from different people. And what they found is that if you look at things like the motor vehicle crash deaths, that many of them not only admit to binge drinking, but admit to having driven under the influence. And about half of traffic accidents in 18 to 24-year-olds is related to alcohol. So it's a huge problem, and it's, in 2001, that was the statistic. 51% of the 8,000 traffic deaths turned out to be alcohol related. So it is something that we want to stop. And what they, Table 1 shows is that if you look at the injury deaths among 18 to 24-year-olds, you can see that from 98 to 2001, a lot of these are actually increasing. You would think that some of them hopefully were decreasing with a lot of the Mothers Against Drunk Driving and the other promotions. One of the biggest changes actually was changing the drinking age. So when I was young, 18 was the age of drinking, and then it changed to 21 sometime after that. And that actually did have a huge impact in terms of stopping a lot of the traffic-related deaths and alcohol-related deaths. So, but they found that there were more motor vehicle accidents. There were more unintentional deaths between that 3-year span. It went up from 9 to 15% in terms of unintentional deaths among alcohol-related injuries in young persons. Non-traffic injury deaths that were alcohol-related went up. College student alcohol-related unintentional injuries went up. Unintentional deaths went up. So there was a huge impact in terms of impacting mortality in 18 to 24-year-olds, and a lot of it was found to be related to alcohol consumption. So there's been various interventions that they tried to use to reduce college drinking problems. So one of the things was to raise the minimum legal drinking age to 21, and that actually did have a positive impact. They then, it didn't seem like it was having a strong enough impact, so then they started the zero tolerance laws, which is that any student under the age of 21, any person under the age of 21 can have 0 alcohol level. It's not like you can get to a certain blood alcohol level, but any amount is considered drunk driving. They tried increasing the price of alcohol, particularly around college campuses, and some of that seemed to work, but not a lot really did. For a while, college administrators were trying to change the laws and actually allow drinking on campus. I think this was maybe about 3 years ago, and some of the big administrators in some of the larger schools were saying, listen, part of our problem is that there's a lot of hidden drinking going on, and if it was more out in the open, that maybe there would be less of these problems. But they never did change the laws within their institutions, and it never really changed the outcome. So I just wanted you to see how some data can be used to evaluate of programs such as alcohol, drinking age, and things like that, they use studies and they use different data to try and understand these. One of the other things that's been interesting over the past 10 years is the case of sugar-sweetened beverage sales in schools. How many of you are aware that a lot of college, high school athletic programs may be partially funded by income from soda machines? Yeah, big billboards. Like, this was a big issue. So you had public health people that are saying, we have to stop having our kids drink soda, and the high school saying, well, this is how we get our athletic programs funded and how we bring money in. So it's a big controversy. So one of the things was they tried to kind of impact the marketing of sodas to schools and trying to reduce the amount that was consumed by children and adolescents, because the whole concept was that this might be contributing to obesity. And so the whole question was whether or not there should really be a self-imposed restriction within the companies, that they kind of say, okay, we're in a school district, we're in a school building, we'll only sell, bottled waters and different things that are healthier alternatives, or how many, just kind of decided, no, we have to legislate this. It really has to be something that we try and change in the books in order to try and see what happens. So some of the places, like California, in '79 started a law that at least 50% of all food for sale during the school day had to meet nutritional standards. West Virginia had some of the strongest ones in place in 1993. They barred student access to food or drinks that had more than 40% of sugar by weight or more than 8 grams of fat per ounce. And so this was not only vending machines, but fundraising events and classroom parties. So a lot of the different districts have tried to act on this. States and local levels have tried to act on it. And industry has basically said that we are going to try and take on some of this responsibility ourselves. And you can kind of see how that's doing by looking at the state by state. So in 2006, the beverage industry said we're going to start some voluntary guidelines to try and make sure that people limit the portions of these high sugar drinks. And it's still, the jury is still out as to whether or not that will make a difference. Now, the last policy thing that I just wanted to cover was the caffeine content. I'm not sure if any of you were aware about the labeling and what's allowed for caffeine, so that's why I thought it might be interesting to see. But from 2005 to 2011, the number of emergency room visits due to adverse events from energy drinks increased tenfold to more than 14,000 per year. So huge amount of problems with these energy drinks. And so in Table 1, it basically goes through different caffeine-containing products and what kind of regulation is there. So if you look at carbonated soda that has added caffeine, something like Coca-Cola, the label needs to indicate it has caffeine, but it doesn't need to say how much caffeine is there. And, but it is limited in terms of the absolute amount of caffeine that can be present. And it goes through different foods and what needs to be on the label and what doesn't. And I found some of this really surprising in terms of, yes, like no-dose or some kind of drugs have to have it, but some of the energy drinks don't have to have the amount of caffeine or the quantity that's in there. And the problem is that many people don't even understand the amount of caffeine that's in the various products they consume. Does anyone know in one of the tables here what was the highest consumption of caffeine? Where you got the most? Yeah. Yeah, Starbucks coffee, the drip coffee, 16 ounces of grande. So comparing the same ounces was 330 milligrams of caffeine, whereas McDonald's coffee, say, is half of that at 160. So a huge difference, but many people are out there and not understanding these different levels. Now, Red Bull, which I know a lot of kids think, well, this is how I'm going to get my caffeine shot or whatever, it's only 80, and yet it's advertised as something to help, stimulate your mind and such. So the whole question is, should we be stricter with the caffeine labeling? I don't know the answer, but these are some of the things that, maybe could be addressed within the policy class next semester. So if you want, you guys can take a 10-minute break. We'll come back at 4:30 for the review and some practice questions.
Dr. Nieves, I was going to say, in fairness to Red Bull, that was only, I think, 8.4 ounces. So I
That's
think,
the size of
right,
the can.
right.
Yeah, I
No.
mean, and the fact is that, my son, every time he has a long drive, he's like, I need to get my Red Bull, and I'm looking at it, and I'm like, why don't I just have a cup of coffee?
Right, from Starbucks, not from McDonald's.
Well, even McDonald's has more.
Yeah, I think when you I don't, McDonald's has like 160, so I think it has
130 or
about,
whatever,
it
so
has about the same as a Red
Ounce
Bull.
for ounce, it might
Right.
have the same, but, it's the same difference. If you finish a cup of coffee versus finish the usual size that they can.
I think
It's
some of that might be
interesting.
psychosomatic too. I think.
Oh, it definitely
Yeah.
is. No chance. Hi.
With the caffeine one, I was interested in it when they were talking about, like, that they'll say, oh, it has chocolate or cocoa, but it doesn't say that it has caffeine
Caffeine
within
in it,
that.
right.
But then I was thinking, and I was like, well, if you look at some labels, like if you have orange juice, it really just says orange juice, but orange juice isn't a chemical compound or anything like that. But if we went in, like, orange juice, citric acid, and everything else that was in it, people would go, I'm not drinking that. What is that? So it's like finding that fine line between when do you start specifying things as like molecules and elements, or when do you...
Because you have to make it understandable to the general
Exactly.
public, and you can't do it that way.
Yeah.
And that's why, at least, for orange juice, most of the ingredients are listed.
Right. But I mean, not
It'll have
in...
orange concentrate and then citric acid, and they'll kind of go through the whole
But
list.
I mean, just like if you had an orange,
Right.
like people are like, oh, it's an orange, but it's like, well, orange is not a molecule, nor is it
Right.
like the things that
That's
are in
true.
there are very different. There's vitamin C, which is also known as this. There's this, which is also, and so
I just
people
thought it was
don't-
weird that this caffeine article, like I've never had coffee in my life, I only drink tea, and they didn't even say how much in tea, how much in hot
Because isn't
chocolate.
there more in tea?
Well,
From what
some
I
people say
understand.
it, but it's a different compound, and whether that compound gets metabolized the same way, I'm not sure.
Right.
And that's why I would have loved for them to cover that. But I think it's too complicated because, like, my tea bag has been in there for 3 hours. So,
Right, so then
it's really
how-
concentrated, and some people just dunk it and then take it out, and
Right.
that's different. So it's really harder to say a cup of tea is this much.
Yeah.
But hi.
I was wondering if you had gotten the request from the colleges yet.
I think I got all of them. I got your email, but I wanted to actually check. But I know I just got what was it? Memorial Sloan Kettering.
Oh, yeah.
I just got that today.
Okay, I had heard
And
that.
I think I had gotten 3 others before, so I think I have them all, but I wanted to, systematically go through and check off your list versus what I got.
Okay.
Because I didn't know if I had gotten doubles on some. Like, I know I've gotten 4 emails, but whether they were the 4 different institutions isn't always clear.
Okay, because I know one of my other recommended things it didn't get through, so I was resending them, and I want to make sure you got them all.
I think I got them all. I'll let you know if I did. And the one other thing that I would need from you is whether or not you decided on a thesis project and what it's going to be.
Oh yes, I just decided, literally, Dr. Cabas just confirmed that I matched and improved my matching.
Okay.
Like just right before the group meeting we just had. So
Okay. All right, good.
yes, it's an epidemiology project dealing with revascularization.
Okay, good. Sounds great. So I will email you back, but I just didn't have a computer where I could systematically look at things.
Yes.
The iPad doesn't work for that.
Yes, I literally just got it approved right before this class.
Okay, good. Congratulations.
Thank you.
How you doing? Yeah, I see you. It's just we haven't like all hung out together in a while. It's true. Just this stuff. What? This basketball? Oh yeah, yeah. Friday I went like clubbing or something with my friend and Saturday I ball. Saturday I did something else. No, Friday I went to Princeton to visit Paul and help him teach me crazy dance class. And then Saturday I went clubbing with my friend from Rutgers. Terrible idea. I'm exhausted still.
I know. I wish I could exhaust.
What you guys do?
Well, but that's not what this is about. Isn't it about getting a blood pressure? So whether they have diabetes. Right, so it's the dentist diagnosis of diabetes?
That's
So
a good
that's
night.
not in the place where you get diabetes. So I'm saying, if it's not unusual place, they always have the doctor. But if you could have a few more cases here than you would otherwise, and so like just improving the sensitivity. Because the other ones might get
It's all
captured
in
in
the East
not
Village.
what you really care about is how many
It's a pretty small
additional kind
place.
of cases you get. And you might be getting some just diabetic sensitivity.
Oh,
But
you
why don't you
did?
email it to me because I should get started and let me
I want to do lunch too. Let's do a really good lunch night. Yeah, Sunday.
But just email them to me. That's off the top of my head what I'm thinking. Well, it just kind of makes sense.
That sounds badass. I really want to do that. You gotta make sure you always have like food and drink up there. They're also like charges.
So I just wanted to like do my presentation. I think that would be disruptive for your listener. But here's a six side shoot. So
Okay, if you
like,
could, yeah, you could use this if you want.
okay, right before you get started.
I'm ready to start, so.
So you're starting like right now?
Right after you announce.
Okay. Hey everybody. If I could just get your attention for a couple minutes. So as I posted in the Facebook group, we're collecting monetary donations for making sandwiches for the homeless. And so we're going to be passing around this donation box right now. If you could spare just $5 or anything that you have right now, we would appreciate it so much. And also, we're also making sandwiches here in Hammer on Saturday from 9 to 11. So if you're interested in that, just shoot me an email or let me know. Yeah, that would be great. All right, thank you.
LL 110 is the room on. Okay, so we're ready to review a whole semester in an hour and a half. So let's start your case control study. What are you starting with here? Which end do you start? Right, they have the disease or they don't have the disease. You asked about prior exposure. Were they or were they not exposed? And that is how you do the case control study, starting with the disease. We put all of this into a fourfold table, and what measure would we calculate for a case control study? An odds ratio. And what's the formula? AD over BC. So that's shown here. So you select coronary heart disease cases and controls. We can't calculate incidence. We're just choosing some people here, choosing some people here. There's no incidence that we can calculate. Then we measure the past exposure, about whether or not they smoked, and then we do the odds ratio, AD over BC. And in this particular case, they got 1.62. So remember, the odds ratio is a good estimate of the relative risk when the disease is rare. So in this case, there were only about 300 cases out of 20,000, so that's pretty rare. And so when you do the relative risk, it's developed disease out of all of the people that were exposed divided by developed disease out of all the people that were not exposed. You get a relative risk of 2. And then if you do an odds ratio, you end up with 2.02 doing the AD over BC. So you get almost the same exact number because that was a rare disease. But it's not a good estimation of a relative risk when the disease is not rare. So in this case, only about, you have about 75 out of 200 that are getting the disease. So that's, pretty common. And so the relative risk here would be 50 that were developed disease out of the exposed divided by all exposed over 100, divided by the number of people who developed disease over all those who were not exposed. You get a relative risk of 2. If you do AD over BC, you end up with a relative risk of 3. So they are not the same, and that is because this is not a rare condition. So how do we interpret an odds ratio? As a measure of an association, 1 implies no association. Odds ratio of 2 suggests that the cases were twice as likely as the controls to be exposed. If it's less than 1, we're really talking about a protective factor. So the whole reason why, we do case control studies in rare diseases is because of this thing here. So recall that for a matched pairs case control study, the fourfold table is different. It's somewhat similar to what Monique talked about, with the twins. But you have the control that's exposed or not, the case that's exposed or not, and these numbers in here are really pairs. And there you do a matched pairs analysis, and your odds ratio here is simply B over C, and you don't care about these other 2. So all you really care about there is B over C. Then we have for a cohort study, and where do we start with the cohort study? Which level? Right, exposed or not exposed, you follow them forward in time, that's what these arrows mean, and determine whether or not they end up with disease. So you look for disease, and what would be the measure of association for a cohort study? Relative risk, right? So you have your fourfold table, you start with exposed, not exposed, they get or do not get disease, drop them into the fourfold table, and that is how we calculate our relative risk. And I'll go through that in a second. Remember, you can have a cohort study that is either prospective, where you started it now and it goes forward in time. I think some of you were confused by, say, a cohort study that started in, 2006, but then they're looking at the data now. That's not a retrospective cohort because they got all the data by the people themselves and then followed them forward in time. So whether the analysis is done in 2010 or 2018, it doesn't matter. It still is a prospective study. A retrospective study, remember, defines the population through some records or something that exists in the past. It's not like you're asking the people in 1988, but there were class records or something available that allowed you to define a population and define their exposure. And today, you can just look to see whether or not they had disease. Yes? I haven't heard the term historical unless they combined a retrospective component with a prospective study. They could have called this historical if they had data from way back then. But it all depends. The only way you can do a retrospective study is if you have good records to identify your cohort and if you have good records that talk about their exposure or not. And so sometimes you'll see something like this in military where they know, like at the time they were recruited, you can look at everyone that was recruited from this year to that year. You know certain amounts from surveys or data that's collected on the recruits, and so you could have some kind of an exposure here, and then today look and see, what is disease status. So that would be one example of a retrospective. Class records or something you can go back in time. Anything where you can go back in time and kind of assemble your cohort in the past and not pick and choose the way we do with a case control and say you have disease and you don't. If you're choosing them based on disease or not here, then that's totally different. That's a case control study. Anything else? So you should know how to calculate incidence rates. And what are the designs where you can actually calculate incidence rate? right. Cohort and randomized controlled trial are the ways that you can calculate incidence rate. And you want to look at incidence in the exposed and incidence in the non-exposed. This is an example where it was done for smoking and coronary heart disease. They either developed or did not develop coronary heart disease. We knew from baseline whether they smoked cigarettes or did not. So we got the incidence in each group, and you can do a ratio of those in order to determine the relative risk. So the cohort study, the measure of association, is a relative risk or a rate ratio that provides a direct measure of the association between the exposure and the outcome. A relative risk is the ratio of the incidence of the disease in the exposed to the incidence in the non-exposed. And it can be cumulative incidence, it can be rate ratio. Just be sure that the denominator is the same when you're doing it. You can't do cumulative incidence for the exposed and then do an incidence rate for the unexposed. So you want to do it both the same way. So here's an example of actually calculating the relative risk. So this is disease status, exposure status. So your relative risk is going to be the incidence rate in the exposed divided by the incidence rate in the non-exposed. So that's here. And I really think that for your benefit to think through these, like the A's and B's aren't really that meaningful as long as you know how to set up a table and know that you're looking at incidence in people exposed and not exposed, because that's the whole way you set up the cohort study or the randomized controlled trial. And the other measure we can do is attributable risk or risk difference, which is really subtracting out the incidence in the exposed minus the incidence in the non-exposed. So those two measures are very important, the risk difference as well as the relative risk. Yes? You can just do it either way. It depends on which you feel more comfortable with. It's not a right or wrong, it's just being consistent. So if you do it as a risk difference, give me the answer as a risk difference, not then say this percent of people. So if you're going to use the word percent, then better make sure that you do the proportion. I always think it's easier and more intuitive just to do the attributable risk. There's really no reason to go back and do the percent. The only reason we do it is, say, if we wanted to do a quit smoking program and we wanted to say, well, what percent of disease in smokers could we stop if we got them to stop smoking? So for public health it's useful, but I think for the purposes of this, either one is fine, and just make sure you're consistent. I mean, the way people got points off on the midterm is they would give me the attributable risk difference and then call it a percent, and it's not. It's a different number. So remember this cumulative incidence, and when you're doing cumulative incidence, just think of it like we have a population and we're just seeing how many cases divided by how many people in the population. We're not adding that concept of time. So when we talk about cumulative incidence, it's 2 cases over 8 people over 2 years. And it's as simple as that. It's cumulative. What is the total number? And sometimes, they'll do this and they'll call it the proportion with disease at the end of the study or the percent with disease at the end of the study. It's simply how many, counting each case only once and counting each person as contributing, just one, not person years, is going to be your cumulative incidence. When we start adding that concept of time is when we start thinking of it more as an incidence rate. So this involves that concept of time. So whenever you see rate, you should be thinking, okay, I should have something about person years or some kind of a time variable in here. And this is the true rate of the disease, and it can help us assess risk. The numerator is all incident cases over the follow-up, and the denominator here is the sum of time contributed by the study subjects while they're at risk for the disease. When a person gets the disease, we stop counting it, and what do we call this? What is the denominator in incidence rate? Person years, right? It's just that concept. So again, think of the words, because the words tell you automatically what to calculate or what to do. So when you see rate, you think of time. When you think of time, you think of person years, not just number of people. So here's our incidence rate example. So remember, we need time here. So once we bring in the concept of time, it's still going to be the 2 cases that we had before, But now it's not divided by 8 because all of these people are contributing 2 years. So there's 12 years here and 1 year here and 1 year here. So it's 2 over 14 person years. And that would be our concept of rate. So when we talk about interpretation of relative risk, if it's 1, there's no association. If it's greater than 1, the risk in the exposed is greater than the risk in the non-exposed, so it's a true risk factor. It can be less than 1, and then the risk in the exposed is less than the risk in non-exposed, and possibly protective. And this is where we would hope a lot of the nutrients would be, although some things like trans fats or whatever might end up in this category. So nutrition can really go into either one of these. And sometimes we talk about deficiency or limited intake as being a risk factor instead of, eating more as being a protective or beneficial factor. So remember, when we talk about disease, this is the Framingham study. You can either talk about incidence rates or you can talk about the relative risk. When we talk about incidence rates, this is something that really helps us plan for the resources, because we have a concept of how many cases of heart disease are we going to have coming into our hospital that we need to have the resources to fix. When we do the relative risk, what are we really getting at there? What are these numbers implying? And it's also a causal criteria. Yeah. Well, it's likelihood, but what's the way that we described it in the causal criteria? Yeah? Size of the effect, or what's another way to say it? Right, the strength of the association. So these numbers, relative risk, the bigger the relative risk, the stronger the association. So it gives us an idea of how strong is that association. Whereas this gives us an idea of how many cases are we going to have to care for of women if they're over the age of 50 and they have high cholesterol. So there's a different way that we use this data. And remember, when I first showed you this data and I showed you the graphic that follows, we had the rates of cholesterol low or high as being these two different colors, and we had it in smokers and non-smokers. And also blood pressure being low or high, and this is using that 130 cut point that we talked about before, and smokers are not. So when we first talked about it, I just said this is graphically how you show the results. But what is one of the concepts that we talked about that maybe is coming into play here between cholesterol and smoking or blood pressure and smoking? Does the excess from the cholesterol plus the excess from smoking add up to this, or is it greater than each sum effect? And what is that called? Yeah. But what's the term? I don't care if it's additive or multiplicative. What's the term I'm looking for? Yeah. No? Yeah? Right, interaction. So this, is there an interaction? We see that if we compare the non-smoker to the smoker, we get this much extra. If we compare the low to the high cholesterol, we get this much extra. So if we add those two together, you'd only get up to about here, but this is much greater than that. And that's why we start thinking about interaction. So just to compare, in a cohort study, the groups you compare is exposed and non-exposed. In a case control, you're comparing people with the disease or your cases to people without the disease or your controls. So here we can compare the incidence rates. We can do incidence rates in a cohort study, and we can do incidence in exposed and non-exposed. And in a case control study, we're really looking at the proportion that were exposed if we're calling them a case, or the proportion exposed if we're calling them a control. Then the main difference between a randomized controlled trial and a cohort study is going to be what aspect? Right, the selection. Are they randomly allocated to it, or are they self-selecting the different behaviors or exposures. So that's the biggest difference between those two. And because these people are self-selecting different exposures, what happens there? What are you leading into? Bias or confounding. And when we do this, we're less likely to have confounding because remember, we have that table 1 and everything kind of evens out between the two groups once we randomize them. So remember that prevalence is existing cases, so it's the number of cases divided by the number of people in the population. And you can have point or period prevalence. As soon as you add that word new cases of breast cancer, then you are talking about incidence. So incidence versus prevalence, think about new cases versus existing cases for that definition. And remember that there is this relational formula, prevalence equals incidence times duration of the disease, and you should understand if you impact one, what is going to be the impact on the others. And you should understand that. The case fatality rate, remember, is the number of deaths divided by the number of people with the disease times 100. So you can have a case fatality rate for cardiac disease, and it's what % of the people that get cardiac disease actually end up dying. You have absolute measures, and those would be the incidence rates, like that table I showed you for coronary heart disease. So the part on the top was the absolute measures, and they have public health importance because they tell us how many people are prevented from getting the disease if the exposure is removed. If you take away high blood pressure by giving people pills, or if you lower cholesterol through the guidelines, whether they're right or not, what happens to the rates of disease? But relative measures we use to try and help us understand if there's a causal relationship, or how strong is the association that we're seeing? How closely are the two related in terms of one causing the other? And these are usually, the relative measures are either going to be an odds ratio for a case control or relative risk for a cohort or a randomized controlled trial. So there's different ways of calculating excess risk, and we talked about this a little bit before. You can have the incidence in the exposed and the incidence in the non-exposed. You can do a difference in those, and that's going to be your attributable risk or risk difference, or you can do a ratio, and they tell you two really different things. It's like how many extra cases of the disease are you getting because of exposure, and this is telling you how strong is exposure related to the disease or outcome. And this graphic representation just shows you to remember that whenever you are dealing with looking at an association, there is always a background risk, and that is why we need controls. So if you do a study and you find a difference in the level of risk in this group versus not having a control group, then what does it mean? We don't really know. What is this compared to? You need a control group because it helps you to get rid of that background risk. Yeah. Right. Because it's a difference in the number of cases. It's not really giving you the odds ratio or relative risk kind of association that you get. So remember that we have the incidence and the exposed, and that's the background incidence plus whatever is due to exposure. And without this group, we couldn't figure out this pink box, or what exactly is the risk that we can attribute to exposure. And this is where we did the calculation, looking at the risk difference, incidence in exposed minus the incidence in the non-exposed. And you can do it as the absolute number as you asked, or you can do it as the %, but they're the same meaning as long as you interpret them the right way. Either one would be correct. I wouldn't take off points. Here's an example where if we think about lung cancer and coronary heart disease mortality, and you're looking at the impact of smoking, the relative risk between lung cancer and smoking is 14 for lung cancer. It's only 1.6 for coronary heart disease. But look at the attributable risk. Why are we having so many more here as compared to here? What drives this difference in attributable risk? not as strong a risk factor, but what is going on here? Yeah. Right, it's just a more common disease. So when you have a more common disease, the attributable risk is going to be pretty high, even if the relative risk is pretty low, because you have so many cases there. And so that's something that also comes into play when you're planning programs and trying to think about, letting go of risk factors or eliminating risk factors. Yes, maybe 1.6 isn't as strong as lung cancer with a 14, but look at how many coronary heart disease deaths we could actually stop if we could get them to stop smoking. So why do we care about confounding and bias? The whole thing is that in the end, we're trying to see whether or not there is a causal association. And we want to get rid of any bias that will make us see a finding that's not really there. If there's confounding, we want to try and control for it. So that's why it's really important for us to think about confounding, think about bias, and how they might impact our results. Because we could get all the way down to here and say it's a significant finding, it's a high relative risk, but if we don't consider confounding or bias, it really means very little, because you have to explore those alternate explanations. So we think that increase in coffee drinking causes an increase in pancreatic cancer, but is it really due to smoking? And that's a confounder. This is the kind of thing that you want to think about, that you want to try and eliminate. And remember that when we talk about a confounder, there is a strict definition. And the definition of confounding is that the confounder is causally associated with the outcome, the disease. So C causes Y, and then C can either be causally or non-causally just associated with the exposure. And because of this dual relationship, the confounder is able to distort this relationship. But it's very important to understand those two options, because that's a lot of the reason why we talked about that the different measures to control confounding work. Because maybe they get rid of the association with the exposure, maybe they get rid of the association with the outcome. And if you do either one, you stop it from being a confounder and all is good. So if we think about an example of confounding, individuals who smoke are more likely to drink coffee than individuals who do not. Smoking, we know, is a risk factor for pancreatic cancer. So when we look at the association between coffee and pancreatic cancer, the odds ratio is 5. If we do a stratified analysis and we look only at people who smoke, this odds ratio is 1, and we look only at people that do not smoke, it's 1. So smoking here is a confounder. It is the only reason why we had that original relative risk of 5. And if we now stratify for smoking or get rid of the effect of smoking, we see that there no longer is any association between the coffee and the pancreatic cancer. And that's how I want you to just think through the evaluation of confounding. And we know confounding is an issue, but it exists, and we don't have to, avoid it. We just have to control for it. So how do we go about trying to look at a real, true risk factor and disease association and get rid of confounding? So one of them is prevention strategies, and this is trying to control confounding through how we design the study in the very beginning. And this can be done through randomization, restriction, or matching, all of these before the study starts or in the design phase. What is it that we can do in the analysis phase to try and control for confounding? Yeah. Okay. Stratification, what else? Multivariate analysis. So where you control for other things in the analysis phase, either one of those are okay to try and control for confounding too, if you haven't done it in the beginning. And I just had a long discussion with an epidemiologist in another facility, because we were trying to say, okay, if we restrict in the study design that we're doing and we say all of them are longtime users of the drug, they all have to be within the same BMI and stuff, then can we still call years of drug use or BMI confounders? And the whole idea is that maybe they still are, because there's such a thing as residual confounding. You can restrict, you can try and control for things, but when you get to that table 1, if there still are significant differences, you better at least evaluate and see whether your confounder still matters. So that is confounding. And the other issue is bias. And remember, this is a systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on disease. And this can be a really big problem, and you can't correct it. And remember, the important thing with bias is that there's difference between the exposed and not exposed, or a difference between the cases and controls. And that's what makes it an issue. So for example, selection bias in a cohort study, exposed was anyone who handled asbestos. 100% of those people participated. Unexposed were workers in other areas who agreed to participate, and they found no relationship between asbestos and lung cancer. But the problem is that maybe the people that were unexposed selected to come into the study because they were at higher risk, and that would, nullify the results. So you always have to be aware of bias and think through whether there is a potential for bias. So in this particular example, what happened is that the unexposed workers, remember, only half of those joined the study, and the ones that participated were at high risk for lung cancer. That's why they cared enough to be part of the study. So the people that were unexposed and actually end up with disease were overrepresented, and that's what this dark arrow is, and that's why you end up with the bias. So there's two different types of misclassification bias, either differential or non-differential. And we can misclassify based on disease status or exposure status. Differential misclassification, the rate of the misclassification differs in two groups. So it could be that you misclassify the exposure, but only in the cases because of things like recall bias. And this can lead to and it's not happening in the controls because nothing they can think of is wrong. They're not really searching their memory. And this could lead to an apparent association where there is none, or an apparent lack of an association. So it really just ruins your results, and you don't know what's going on anymore when you have differential misclassification bias. So here's an example of that. Misclassification of unexposed as exposed is more common in the cases than the controls. More of the women that had a baby with a congenital malformation are saying, yes, I had an infection, when really they didn't. It's only happening in the case group, and that is why it's differential misclassification. If both of them were more likely to respond differently, it wouldn't be as much of an issue. Non-differential misclassification is simple inaccuracy. So a lot of times you guys confuse these two. So you say that, well, the people can't remember when they're telling me what they ate 5 years ago. Well, that's the same in the cases and the controls. So that's not a bias. That's just poorly collected data. And in this case, it always dilutes the odds ratio or relative risk towards 1, or towards showing no association. So, it's important to understand the difference between non-differential and differential misclassification. Yes? Yeah, usually you can, at least in your discussion state, chances are that there was some inaccuracy in filling out this, and this would have diluted the effect towards 0, so we believe there might be even a stronger association. Sometimes people actually will estimate what the difference is, and then try and bring up their odds ratio, say, well, we got an odds ratio of 1.7, and because of this non-differential misclassification, we think it's really 1.9, but that's a little bit more hokey than what I like to do. So interaction, concept I talked about a couple of minutes ago. When the magnitude or measure of an association between the exposure and disease meaningfully differs according to the value of some third value. And this is also called effect modification, or effect measure modification, or heterogeneity of effect. And that was the example I showed with blood pressure, cholesterol, and smoking, and the whole idea there. And think about how you would express this if I asked you about this. So this was a slide from the class then, and if you're looking at smoking, caffeine use, and delayed conception, you could say that caffeine use modifies the effect of smoking on the risk of delayed conception, or there is an interaction between caffeine use and smoking in the risk for delayed conception, or caffeine is an effect modifier in the relationship between smoking and delayed conception. Any of these would really be reasonable. And the other terms that sometimes are used when we're talking about interaction is positive interaction or synergism, when the two together actually makes it much greater, or negative interaction, but very rarely do we actually see that, or antagonism. So one of the examples that we had for interaction was if you were exposed to hepatitis B infection, so you were either negative or positive for that, and whether you were negative or positive for aflatoxin. So if you were doing this, and I didn't have this number here, what would be the expected value that you would expect to see here instead of the 59.4? How would you calculate that? Yeah. Well, tell me what numbers you're using. Right, so you take the effect of just having aflatoxin, multiply it times the effect of hemoglobin, chronic hepatitis status, and you multiply these two, and you're going to get 24.8 is actually the number you get. And is that smaller or larger than this? So it's smaller, so it's showing that there is a potential for interaction here, because the number we get is much greater than what we would expect if we simply multiplied this times this. So just thinking about this was done for the cardiac risk factors, but you always want to try and categorize evidence by the quality. Clinical trials are the best, particularly if they're both randomized and blinded. Think about the reasons why we randomize, why we blind, what's the primary purpose. Then they could be random but not blinded, and non-random. Then there's cohort or case control studies, and then there's other cross-sectional studies, case series studies, ecologic studies, much lower evidence than either the clinical trial or the cohort or case control. Think about the guidelines for evaluating causality. What are the criteria we use? And I had given you this for your papers, thinking about the major criteria: temporal relationship, the exposure needs to precede the disease; biologic plausibility, it makes sense; consistency with other findings; and that you've thought about alternate explanations, including confounding and bias or anything that could have made the association occur. You don't always need, but they help if you think about dose response or the strength of the association, or if it's something where you can remove the effect and see what happened. So when we talked about screening, remember we talked about the concept that you do screening, and do you end up with having a delayed death or no death from the disease, or you have an earlier diagnosis but you die at the usual time? What is this called here? Right, that's lead time bias. So it only looks like the person lived longer because you diagnosed them earlier. It has nothing to do with actually delaying the death or stopping death from occurring. So lead time and 5-year survival, these things can influence each other. Lead time bias can possibly affect 5-year survival. There can be an illusion of better survival only because we had earlier detection, and that's lead time bias. And in reality, there would be no benefit of the screening. We have no change in the death, no delayed death. That is when it's simply a bias. So here is the sensitivity and specificity in a screening example. So here you had 100 people that actually had the disease, 900 that didn't, and you had a screening test. And if we want to look at the sensitivity, you're talking about the ability to correctly identify those with disease out of all the people that have disease. So the sensitivity here is 80%. And then we talk about the specificity, and that's really the ability to detect, this was the ability to detect disease in those who have it, and then the ability to correctly identify those people who don't have disease in those without disease is the specificity. And here it's 800 divided by 900. How many were negative on the test out of how many actually didn't have the disease? So how good are you at detecting that? So you should know how to do these two measures. You should have an understanding of the relationship between specificity and positive predictive value. The general idea here is that as you decrease the prevalence from 50 to 20% here, you decreased your positive predictive value as well. And that is why we try to screen people that are higher risk, because then we're getting a higher prevalence. We're forcing a higher prevalence by making these people at higher risk. We talked a little bit about twin studies, concordance and disconcordance. And if you have a genetic association, where would the concordance be higher, in monozygotic or dizygotic twins? Monozygotic, right? Because they have a stronger genetic relationship, and so there should be a stronger association to disease if it is genetic. The relationship between genetic and environmental factors. Certain diseases are largely genetic, or others are largely environmental. But even if it's largely environmental, you still can have genetic susceptibility, and there could be an interaction between genetic and environmental factors. So that was just trying to highlight some of the features of the last few lectures. It's not totally all that I expect you to know for the final, but it is like a highlight of what I'd like you to definitely know. So here are some questions. Which of the following is or are an approach or approaches to handle confounding? E, all of the above. Which can you do in the design phase? A and C. And then the ones in the analysis phase are the stratified analysis or statistical adjustment, or B and D. So it has been suggested that physicians may examine women who use oral contraceptives more often or more thoroughly than women who do not. If so, and if an association is observed between phlebitis and oral contraceptive use, the association may be due to what? C, surveillance bias. The guy is looking more closely in the people that were exposed as compared to the people who were not exposed. And if he did this, what would be the impact on the relative risk? It would be higher. He would lead to an overestimation of the effect. Is this differential or non-differential? It's differential, right? Because it's only happening in the exposed women. It's not happening in the non-exposed women. Yes? Because interviewer bias is when the person is actually asking the individual, like, what was your exposure? What are your, that's not an interviewer. The interviewer is usually asking about exposures in a case control, or maybe asking about other exposures, but this is someone that's measuring the outcome. So your outcome is phlebitis, and that's what you're worried they're looking more strongly for, and so that's why it's surveillance. Because they're not just asking them if they have it, they're doing a more thorough physical exam to look for the outcome. And surveillance is what we do in a cohort study to try and see who gets the disease and who does not. Okay. So in this study, this is if you had an additive model of interaction. Can someone tell me what should be in this cell here? Yeah. You add them all. Yeah, so if you had an additive interaction, you would have the difference here, which is 4. You'd have the difference here, which is 5. So it's 4 plus 5, but you have to add in the background, which is 3. And that's what you'd expect there. So it will be the sum of 5 plus 4. So the 5 here, the 4 here, that's the difference, and the 3 here, it would be all of them together would be 12. So, yeah. Yes. So either way would be fine. Yes. Was there a question here? All right. So, yes. Okay, so what she said is, can you also do it that the difference here is 4, and so can you do 8? The difference here is 4, so if you go from here and you add the 4 cases, this would be 12. So you could do it that way. Or you could do it the other way. Yeah. I mean, so then you have a double check on yourself, because you can also do calculation both ways, and it should always equal the same number. So you kind of have a double check on yourself. So now let's take this and change it into the additive model. So now we know we had 4 additional cases here from the last time. It was 3 versus 7, so 4 additional cases is going to go in this box. We have 5 additional cases is going to go here. So now what would this number be? You had it before. Now it's going to be 9, okay? Because it's just how many additional cases do we have from the combined exposure of both of these. So you have the 4 extra here, the 5 extra here, and together they make 9, and that's what would be here. So you can also think of it as a multiplicative model. If you were going to do that, you would have to go back to this thing and say, what is 7 divided by 3? And what is 8, 7 divided, so it's going to be 7 divided by 3 is 2.33, and 8 divided by 3 is 2.66. So those would be the numbers that you would have in this number here, 2.33 and 2.66. And then you'd multiply them, and that would be the number that would go in here. So for multiplicative, you're just assuming this is 1, and then you're seeing what is the multiplicative difference between my numbers here, 7 divided by 3 or 8 divided by 3. And they're 2.33, 2.66, and you multiply those two to get the last number over here. And that's really kind of looking at the relative risk. So you have a relative risk of 2.33, 2.66, and if you multiply them, you get 6.2. Yes? Instead of a real-life example, what I'd rather have you think about it is if we're using absolute numbers, then you should be thinking about additive. If we're doing relative risk, then you should be doing multiplicative. I think it's an easier way. It's not like there's one example where it would be additive and one where it would be multiplicative. It could be the same thing. But the default here is how many extra cases. It's almost like excess risk here, excess risk here. What's the excess risk of both? And here it's 1, because that's the default for relative risk. What's the relative risk here, relative risk here? So what should we get by the combined relative risk here? So don't think of it as a scenario or situation, but think about it in terms of what are you given. You're given a relative risk, that's a multiplicative kind of value, so you should be thinking of a multiplicative answer here. But it won't be that complicated. All right, so here we have a case control study of the relationship of radiation exposure and thyroid cancer. 50 cases admitted for thyroid cancer and 100 controls admitted during the same period for hernias were studied. Only the cases were interviewed, and 20 of them were found to have been exposed to X-ray therapy in the past based on interviews and medical records. The controls were not interviewed, but everyone looked at their hospital records, and they only had 2 controls who were exposed to X-ray in the past. So based on the description given above, what source of bias is, and read questions carefully all the time, that's why I choose some of these, least likely to be present in the study? What kind of study is this? So is recall bias usually a problem? Is bias due to controls not being representative a problem? Is bias due to different methods of ascertainment of exposure in cases and controls a problem? That's a potential problem, right? Is bias due to loss of subjects from the control group over time a problem? No, that happens in a cohort study, right? This is a case control study. So loss to follow-up is not something we're concerned about in a case control study. So that is the least likely thing to occur. So the correct answer there is D. Okay, in a large case control study of pancreatic cancer cases, 17% of the patients were found to be diabetic at the time of diagnosis, compared to 4% of a well-matched control group. They were matched by age, sex, ethnic group, and several other characteristics that was examined for diabetes at the same time as the cases were diagnosed. It was concluded that diabetes played a causal role in pancreatic cancer. And this conclusion, and you have to finish this, is it correct? No, we can't really say it's causal, right? It was a case control study, just one study. Maybe incorrect because there is no case, there is no control or comparison group. We had a control group, right? How about maybe incorrect because of failure to establish the time sequence between onset of diabetes and pancreatic cancer? That's a problem, right? In case control studies, it's always a problem that we're not really sure about time order. We have them currently with disease, we're asking them about past exposure, but we don't really know which occurred first. So the correct answer there is C. So all of the following are important criteria when making causal inferences, except which one of the below? So A could be biologic plausibility. That's part of causal criteria, right? Dose response can be. Consistency with several studies is. Strength of the association, how big is the odds ratio, relative risk. All of these are very reasonable for causal inference. But predictive value has to do with screening tests. It has nothing to do with causality. So the correct answer is E for that one. Ecologic fallacy refers to, you all should know this, we had it twice on the midterm. So I heard C. It's ascribing the characteristics of a group to every individual in that group. You can't take group data and apply it at the individual level. So here we have an investigator who's examining cases of fetal death in 27,000 pregnancies and classified mothers according to whether they had experienced sexual intercourse within 1 month before delivery. It was found that 11% of the mothers of fetuses that died and 2.5% of the mothers of fetuses that survived had had sexual intercourse during the period. It was concluded that intercourse during the month preceding delivery caused the fetal deaths. So what would you say about this conclusion? What? You think it's correct? I'm sorry, I'm reading the wrong thing. It is A. I was at the question above that, so it may be incorrect because mothers who had intercourse during the month may differ in other characteristics versus those that did not. So we want to control for confounders. We want to think about bias, get rid of those alternate causes before we go on and take that as truth. Okay, so this is getting at some of the causality. So factor A, B, and C can each individually cause a certain disease without the other two factors, but only when followed by exposure to factor X. Exposure to factor X alone is not allowed by the disease, but the disease never occurs in the absence of exposure to factor X. So factor X is what? B, right, it's necessary. It never occurs without it, but it's not sufficient. It can't do it on its own. It needs to have some of the A, B, or C. And what about factor A? D, right, because it's neither necessary. You could have A or B, and it's also not sufficient. You need to have X as well. So the correct answer there is D. Okay, a case control study is characterized by all of the following except, again, read questions carefully. So a case control study is all of the following except. C, right? Incidence rates. You guys should really, really get this correct. Incidence rates may be computed directly. That is not true, right? We've talked about that a lot, and I don't want to see any of you calculating incidence rates from case control studies on the final. So now you have residents of 3 villages, I think this might have been on your midterm, with different types of water supply were asked to participate in a survey to identify cholera carriers because several cholera deaths had occurred in the recent past. Virtually everyone present at the time submitted to examination. You have the proportion of residents in each village who were carriers were computed and compared. Classify this study. A, cross-sectional, right? At the same time, you're asking about disease and your village water supply. So exposure, disease, same exact time is your cross-sectional study. Okay, the physical examination records of the entire incoming freshman class of 1935 at the University of Minnesota were examined in 1977 to see if their height and weight at the time of admission was related to their chance of developing coronary heart disease by 1986. What is this an example of? It's D, it's a retrospective cohort study. You assembled the class from their records back in 35 when they were at University of Minnesota. The follow-up has already occurred, but you have data that preceded that follow-up, and that's why it can be a retrospective cohort study, or D. So in a case control study, which of the following is or are true? I'm sorry. I mean, it could be. That's what I'm saying, that could be a name that they use for it, but in terms of what I've taught you and what would be correct, it would be a retrospective cohort. But I do believe that that's what they're talking about if they use the term historical and cohort. If they don't use the term cohort, then I don't know what they're talking about. Like sometimes they do studies where they have a historical control to a current procedure, and then they might use the term historical, but it's not necessarily a cohort study. It could be almost like cross-sectional or, asking about what procedure was done in the past. So any other questions? Okay, so back to a case control study. Which of the following is or are true? I'm sorry, I can't hear. Right, it's E. It's A, C, and D. Why is it not B? You can't get rates, right, in a case control study. You can't calculate those ever in a case control study. The major purpose of random assignment in a clinical trial is to do what? You said E? No. No? D, it's D. Ensure, what do I always say? If randomization worked, what's going to happen to that table 1? Your study groups are going to be the same when you look at the baseline characteristics. That's the whole point of randomization. If you don't randomize and you let them self-select, that table 1 in all of our cohort studies has pretty much been filled with differences. As soon as you randomize, you hope that you get rid of that differences that existed between the study groups. And that really is the main reason why we randomize, to make sure that they're even at the time you start the study. So you have an advertisement in a medical journal, and it said that 2,000 subjects with sore throats, which mine is really bad right now, were treated with our new medicine. Within 4 days, 94% were asymptomatic. The advertisement claims that the medicine was effective. And what do you say based on this evidence about this? I'm sorry, I'm hearing different. E, right? Because it may be incorrect. There was no control or comparison group. How do you know that in 4 days everyone wouldn't have been better even if they didn't take whatever medicine or drug there was? Okay, there's a physical examination that was used to screen for breast cancer in 2,500 women with biopsy-proven adenocarcinoma of the breast and in 5,000 age and race-matched controlled women. The results of the physical exam were positive. A mass was palpated in 1,800 cases and in 800 control women, all of who showed no evidence of cancer at biopsy. So if we were going to just do this right here, can anyone tell me what the table would look like? Right, 1,800 is going to be here. $2,500 is here, right? It's the total number, so then we're going to have the difference here is going to be 700. And where did you say the 800 is going? Up here, right? And this is 4,200. And so here is 5,000 people without the disease, right? So everyone clear on how you get that? So now, if we wanted to do the sensitivity of the test, what is your sensitivity going to be? 1,800, right? So it's the number up here, the people that were positive on the screening test and were truly positive, divided by what? 2,500. Okay, and so that's 72%. So what is going to be the specificity? Right, how many were negative on the test divided by 5,000? How many were truly negative? And so this actually equals 84%. And the last thing, the positive predictive value. So it's 1,800 on the numerator. And what's the denominator? It's the sum of these, right? So that's the 2,600 that you're getting here. So out of 2,600, and so that actually equals 69%. So everyone should be clear on how we got that, and you should be able to do that on the exam. So if it's not clear, write that all down and make sure that you can go home and actually do that. So here is a cohort study, and we're looking at the relationship between car exhaust exposure and severity of asthma. And these are the results that you got. The relative risk for mild asthma was 1.5, moderate asthma 1.9, and severe, spelt wrong, asthma was 3.0. Which aspect of causal thinking is best illustrated by this example? It's B, right? It's dose response. It's as you go from mild to severe, what is the relationship? And it's stronger at the more severe disease. So the answer there is B, dose response relationship. So in a case control study, cases tend to give more false positive reports of being exposed than do controls. As a result, what is that called, first of all? It's recall bias, and as a result, the likely effect on the study findings will be, A, it's overestimation. You falsely elevated what the exposure was in the cases, so that's going to make it look like a much stronger association than it is in reality. There's a correlation shown between national consumption of coffee and gastric cancer mortality. But individual coffee drinkers do not have an elevated risk of developing gastric cancer. This is best described as, right, B, ecologic fallacy. You can't assume that the data at the population level will hold true at the individual level. In a cohort study of hormone replacement therapy and the risk of developing heart disease, high socioeconomic status is associated with both the use of hormone replacement therapy and the risk of developing heart disease. This type of error would most likely result in D, right? It's confounding. It's meeting the definition. It's related to both the exposure as well as the disease. It causes the disease. So it's meeting that strict definition of a confounder. So you should know the definition of a confounder and why we could say this is a confounder. In a cohort study, the effects of an environmental exposure on the subsequent severity of disease, the investigators assessing the disease severity do not know the exposure status of the subject. As a result, the effect on the study findings will be what? C, it's going to have no effect. What would it be if there was actually, if they knew and they they could overestimate or underestimate, depend on their bias. So if they had, that could be some kind of a surveillance bias, but because they don't know, you're taking away that, so there will be no effect. Oops. Okay, 2 pediatricians want to investigate a new laboratory test that identifies streptococcal infections. Dr. Kidd uses the standard culture test, which has a sensitivity of 90 and a specificity of 96. Dr. Childs used the new test, which is 96% sensitive and 96% specific. If 200 patients undergo culture with both tests, which of the following is correct? Can it be A, Dr. Kidd correctly identifying more people than Dr. Childs? No, because the sensitivity would be flipped from what it is, right? Could it be B? Right. Dr. Kidd will correctly identify fewer people with streptococcal infection than Dr. Childs. That's strict from the definition. And the specificity was the same, so that's why it can't really be C. They both had 96% specificity. Okay, so you have a new screening program in a certain country. The program used a screening test that is effective in detecting cancer Z at an early stage. Assume there is no effective treatment for this type of cancer, and therefore that the program results in no change in the usual course of the disease. Assume also that the rates noted are calculated from all known cases of cancer Z, and that there were no changes in the quality of certifying deaths for this disease. So what will happen to the apparent incidence rate of cancer Z in the country during the first year of the program? Right, because you're going to have an increase in the diagnosis, right? So what will happen to the apparent prevalence rate of cancer Z in the country during the first year of this program? It'll increase because you're having an increase in incidence, there's no change in duration. What will happen to the apparent case fatality rate for cancer Z in the country during the first year of the program? Right, it's going to decrease, or B, because the number of deaths divided by the number of cases. The number of deaths is the same, but the number of cases is increasing, so overall this will show as a decrease. And what will happen to the apparent mortality rate from cancer Z in the country as a result of the program? C, it's going to stay exactly the same.